for over 35 years. I'm one of the original members of it used to be called the North American Menopause Society and the International Menopause Society, and we just couldn't, even when I was on the board, I'm still very involved. The meeting was last week and gave a lot of talks. And I don't know if any of you remember Gail Sheed, who wrote this book called The Silent Passage. Do any of you remember any of that? I mean, because it's so, I mean, we got her, I was up north, and it was, for a little while in the 90s, we tried to bring it out of the closet. I mean, people were like clutching onto this book, and it was in Vanity Fair. But then the word menopause was like, shh, shh, don't talk about it. And so I am so thrilled, and it's really from social media, good and bad, to be honest. What's good is that it's finally mainstream, and we're talking about it all, and we're talking about dry vaginas, and we all know it all. And hot flashes, no woman should suffer with either one of those conditions, which is hot flashes, sleep. There is so many good options for women now. And the vaginal stuff, I mean, like, it blows my mind. We now renamed it to genitourinary syndrome of menopause. When I say we, because I've been very involved in clinical research and treating women for the last 35 years. I mean, I literally was having babies, delivering babies, found that part of my life had to change because those 3 babies needed more help around, and then I started doing research in menopause. And I'm just sad that it's taken till now for it. Menopause is having a moment. Our organization went from 2,000 members 2 years ago to 12,000 this year.
Nice.
And it's amazing. But everybody, the only problem I have is that there's a lot of misinformation out there. And one of the things that we're really trying to do is to really give accurate information and choices to women so they get the right information, because there's a lot of misinformation out there. So I can tell you who to follow. The minute I see people in our complex clinic, I have to say, okay, who are you reading? Who are you following? So it's challenging. But no woman should ever be suffering the way that we saw these people suffering. And I mean, when I went to med school, I was, it was the year that it went from like 7% to 15% women. And very few women went into OBGYN. I mean, I was really like one of those who said, I'm going to take care of women, because I couldn't believe that there were all these men. I mean, all those comments you heard, I mean, that was so right on. I mean, really, it's mind-blowing. So ask your questions.
Yeah. Okay, I have 2 questions. My first question is, what about people, in this show there are people that have cancer, or I've heard people that have like high cancer risk. What do women, what about those women, if they do have those things like a dry vagina or things like that, are there things for them that they can do?
Absolutely.
And what are those things?
What's the saddest part, if you want to find a good practitioner, you got to find, I mean, like, I'm sitting there thinking every single woman here I could have helped. But it makes me sad that you never found the right people. So even with cancer survivors, I have a breast cancer survivor clinic. We were part of a big group to say we have to educate our colleagues, we have to educate starting at med school or whenever. Women need to know, besides lubricants and moisturizers, which actually just kind of put a Band-Aid over the situation, but boy, let me tell you, when it's burning and it feels like what you described, sandpaper, you need local vaginal estrogen, or really low doses. And even breast cancer survivors now, most oncologists are okay with that. We have lots of choices. If we, and so women should not be suffering. And then we have these incredible women's health physical therapists that help us. Like, there are lots of women. I mean, believe me, when somebody's diagnosed and you're going through treatment, the last thing you want to do, that most people don't want to have sex. But there's going to be a life after sex, after cancer treatment. And that's what we always try to see people early on, to say, we really want to help you get through this, but there's going to be a life at the end of the tunnel, and you want to keep it healthy. And so we really, there's a lot that can be done. And then if you can't take hormone therapy, we have outstanding alternatives. And You know, the problem is there's been a 20-year gap in knowledge, and you may hear about this in the news. There was a whole crowd of medical students and nursing students, and they had 1 or 2 lectures on sex and 1 or 2 lectures on midlife and beyond menopause. And finally now it's changing. But I mean, seriously, I do a clinic with board-certified OBGYNs, teaching them, where I taught a few of them in the clinic at UCSF, but they knew a little, but teaching them now, like really donating my time to give them the expertise that I've known. And I was part of a group of people that, you'll hear, well, you're not gonna be here that night, but like Dr. Sharon Weiner's another one who knows. We're old-timers that have been doing this for a long, long time. Yeah, I know Lulu's father-in-law was one of, you know, he was old, he was ahead of me. I mean, but I learned a lot from him. He is an endocrinologist, retired. So, yeah.
Dr. Kagan, thank you for being here tonight.
Yeah.
I just want to ask, I started HRT just about a year ago. How long is it safe in your professional
How long is it?
opinion?
Let me
Can
repeat
you be on the patch?
Yeah,
all three?
first of all, not everybody has to be on a patch, I have to tell you. And there's some message out there, and it's not just a patch, it's transdermal versus oral. And you know, we're now recommending many women staying on hormonal contraceptives till about 55. So why when you turn 56 or 57, if you're healthy, you can't be on a pill? I mean, there are pills that are fine. It's just that as women get older, 60, 65, we want transdermal delivery. And it's not just a patch, there's gels. That one with the patch falling off and not working, yeah, take a pill, but there's gels, there's other things to do, there's other delivery systems. There's no data to say that when somebody is on menopausal hormone therapy, and you notice I'm not saying HRT. HRT, we're trying to change terminology, but the media and the whole world out there is still trying to say HRT, because when you Google, that comes up first if you put HRT. Back in the day, it was more replacement. We do replace women who have what's called premature or early menopause, but for the average age of menopause, women 45 to 58, or even 40 to 45, some people do, or even before, we're trying to say hormone therapy, or the international community is saying menopausal hormone therapy. We're giving therapeutic doses of estrogen and a progestogen if you have a uterus. So that's why we're trying to change the terminology, but whatever. Extended use of hormone therapy, there is not 1 ounce of data to say you have to stop, and at all. It's a mutual shared decision. And yes, as women age, they're at more risk for different disease, strokes, and cardiovascular. We reevaluate yearly, and if you are a healthy person, you know, you may decide, I will tell you this much, if women taper or go off of estrogen, about 50 to 90%, depending on the study you read, have to go back on something, mostly for hot flashes, or, believe it or not, there's this huge study that was done in the last, over the last 30 years, called the Study of Women Across the Nation. When I trained, we used to think, hot flashes, just grin and bear it, 3 to 5 years, 2 years, you know, whatever, get through the change. No, what they found was the median duration of hot flashes following women from before, through the peri, and after was 7.4 years. Do you know what that means?
What?
That means some women are suffering for 14 years. But I mean moderate to severe, the ones that you are sweating, you have to stop what you're doing. You know, women are all over the workplace now. If you go to the first page of our society, which is www.menopause.org, it's all about women in the workplace. And there is no reason you may have to stay on it for that. Or some of my patients will say, I want to stay on it to preserve my bone mass. Did you know that you start losing bone mass before your final menstrual period? So there's a lot of education that has to be put out there. Here's the problem. Years ago, when somebody went on hormone therapy, and they went and saw their internist, I mean, they would often say, you've been on it for 5 years, you got to stop. And they make you stop it based on this big study, didn't apply to what you're on, and it would drive me nuts. I said, don't let anybody tell you to stop it. You come back and see me. And because I don't take my patients off their statins and their hypertensive meds, you don't let another doctor take you off of this. You come and discuss. It's a risk benefit. I have many women into their 70s, 80s, 90s on menopausal hormone therapy.
Oh, wow.
Yes, lower doses, different delivery systems, honestly. So there's no, if I tell you that the median duration is 7.4 years or 14 years, there are many women that or women stop it, then they can't sleep. Or, I mean, I'm not talking about the vaginal. You can take that for the rest of your life. And every woman should be on something in the vagina, I'm telling you. And very few women cannot be. For their bladder, that's why we changed the name, genitourinary syndrome of menopause, because you can get this urgency, frequency, and you can also have lots of urinary tract infections. So you should be.
No, sorry.
Yeah, absolutely. So, the systemic therapy, which is the patch, the gel, the pill, we just kind of lower doses, and we do switch to transdermal. And the reason why people do a lot of transdermal is because you avoid something called the first pass, where you swallow it, it goes through the liver. There's a slight increased risk of blood clots with the oral versus the transdermal delivery, okay? But it doesn't mean you can't be on an oral. By age 60, most of us are trying to urge women, because age is an independent risk factor for, strokes and blood clots and all these other things. But we basically try to urge people to go on transdermal delivery as they age.
Transdermal meaning the patch.
Well, the patch is one form of anything that's absorbed through the skin.
Okay.
There is a great gel. There's a few different gels. Not everybody, I know, like some women don't want to be on a patch. Believe me, I have those women that don't want the patch on. They're dating. They don't want somebody to know they have a patch on. There's gels that dry. You don't want to transfer it. But pills. There's a lot of great pills out there. And in your 50s, there's no reason why you can't. If you're healthy, you don't have certain contraindications. If you smoke, hypertension, any of those high risk factors, you should be under transdermal delivery. And if you have a uterus, you have to be on a progesterone too. Okay. Yeah. Oh, lots of questions. I love it.
You're not mentioning the pellets. I use the IoT, the injectables.
You know why I'm not mentioning it?
Well, I want to ask you.
Okay, that's what we're gonna hear me. Dr. Bronstein, if he was here tonight, he'd be along with me. Pellets are not FDA approved. They are dangerous. I am saving women day in and day out from getting pellets. I have to say, it's not the pellet that's the problem. The company needs to do studies. We've talked to them. The problem with the pellets is they get into your system subcutaneously. You have no clue how much you absorb. The blood tests that you do, or forget saliva tests or urine tests, mean nothing. It's just that one moment in time. They give you either super physiologic levels or not enough, and they can linger for a really long time because there's just no standardization to the release of that hormone. And with all due respect, that we can show you study after study of all the dangers related to pellets, and I'm happy that you're not in danger, but I would urge you to find somebody to transition you over to, there isn't any, you should be taking FDA approved drugs for a reason, and not this compounding crap either. And the reason, no, I'm serious, because you have no idea what you are getting, and they have taken some of those products and analyzed them, and some are so dangerously high. Yeah, I've seen people with pellets get stroke, endometrial cancer of the uterus, because it's just not regulated in the amount. You take an FDA approved pill, gel, or transdermal estradiol, they are regulated. That's why they recall batches all the time, where they go and randomly check, because it's really, there's an advantage to doing an FDA approved drug. We sometimes order a compounded if somebody has an allergy to the incipient or the ingredients in something. But when you can use an FDA approved drug,
But
they're
isn't
going
it
to
true
protect
though,
you.
testosterone is FDA approved for women?
I did every testosterone trial in the United States. And it's not approved for women. But we do use it off-label, but it should not be compounded. There is a 1% generic male testosterone, and right now, until further notice, we're trying, you have to use like a tenth of the amount. But testosterone has one and one only indication right now. The social media will tell you it'll make you feel better, and everybody should be on testosterone for cognition and for your muscle mass, and there is no data to support any of that. Follow on Instagram, one of my colleagues from Australia, who's the world expert on testosterone, is Professor Susan Davis, and her daughter set her up to give like these little vignettes to counterbalance all the stuff, misinformation that's being promoted. There's an indication for testosterone for women for a specific condition called hypoactive sexual desire disorder. And this is not just low libido because you're overloaded and 2 careers and kids and, you know, it's a long-term marriage or a marriage you don't want to be in or a partner you don't want to be with. It's really a specific condition that the sexual medicine world really can diagnose, and it really, like, the light bulb went out. So many and it's only for peri or postmenopausal women. But we also have another drug that's been approved for women that hasn't been approved. It's called the ADDI, you know, flibanserin for premenopausal women, and there's studies for post also. It's a pill that you take that works. The biggest sex organ in it is in your brain. So the testosterone that we do give to women if they have this condition called hypoactive sexual desire disorder is something that you use in 1/10 of a dose of a male dose. And there's no correlation. If you're doing all these blood tests for testosterone, you know, there's no correlation in any of the studies we've done with the level of testosterone. Women's testosterone start declining at age 35, actually. And there's no correlation with the level with outcomes, like we have validated tests for low libido or this condition called hypoactive sexual desire disorder.
What is that?
Huh?
What is that condition? If
It's a
not
condition
just
that occurs in about 10 to 12% of women, both pre and postmenopausal, which is felt to be due to imbalances in the frontal lobe and various neurotransmitters. That's why the ADDI pill works on a transmitter. All of it with a downstream effect of increasing dopamine, like trying the feel-good drug. There's also a shot, an on-demand shot called Vyleesi, maybe you've heard of it, but for premenopausal women. But for postmenopausal women, there's a way in which we can diagnose this condition with a big, long interview and it's validated. But I will say, a lot of docs just like give it out like water, and it doesn't work. There's in all the sexual medicine studies, all of them, and I've done tons of them, there's a 40% placebo response to everything. You know that? So really, what most often people, and I'm not talking about arousal and orgasms, I'm talking about just desire. And when you're in a long-term relationship, you know, and you go through menopause, first you gotta get rid of the pain. Like first we go through a whole questionnaire and we find out, like there's this thing that we go through, is there a reason? You know, are you having an illness? You've been through cancer. Your partner has a problem. You've just had, you know, going through menopause. You have painful sex. There's no way anybody with painful sex, you know, can have this condition. You gotta fix the things we can fix, and then if everything is fixed, and it's just the light bulb went out, and you need to kind of get it going again. Because I have to tell you, the reason the FDA didn't approve testosterone is because in the good trials, over placebo, dummy pill, dummy patch, there was maybe what they called one satisfying sexual encounter a month. And they were afraid to approve it because they felt it would get out there and the wrong people would use it when there may be some risks with it, okay? So they wanted more long-term studies. And unfortunately, right now, it's challenging to get people to do long-term studies. In Australia, that woman, Professor Susan Davis, they have managed to get a 1% testosterone approved for women. And I think a lot of people in the know are trying to get it so we can get it from there here for women, so they can actually not have to do this thing where they measure out 1/10 of the male dose. Yeah.
Hi, thank you so much for being here. I have Kaiser as my health insurance.
That's fine.
And I last year finally realized I was in perimenopause, and then I thought I went through menopause.
Yeah.
And then they gave me a patch, and now I'm bleeding again.
Yeah, yeah. Well, people can be bleeding not from having periods again. Sometimes people are bleeding because they're having abnormal bleeding from hormone therapy. So that just needs to be evaluated. You can't say, I mean, I will say, typical perimenopause is just like you heard here. And honestly, I agree, there's no blood tests that help us. And if people are doing urine, blood, saliva, forget. I mean, actually, I'll never forget your father-in-law on the stage saying the only thing that's stable in saliva is cortisol, and that we shouldn't be doing saliva measurements. We shouldn't be, I mean, honestly, there are few and far between reasons for a blood test. Sometimes there are reasons we do it, but it's not gonna help us make the diagnosis at all. Because what happens in the perimenopause, it is like PMS all month long, and your hormones are all over the place, and every single day, every single month, it can be different. So you come in, you think you've gone through menopause, you're having all the symptoms, we counsel someone, we give them hormone therapy, and then all of a sudden they come back and say, oh my God, I'm bleeding monthly and I'm having my PMS symptoms. They're back to having regular periods again. That's classic perimenopause. So, but being bleeding does not mean that's a period. See, that's when anybody's on hormones and they're bleeding, they need to be evaluated with an ultrasound and then some other evaluation. And everybody who was describing all this bleeding tonight made me sad, because nobody should have to, I mean, it happens, but that is totally diagnosable. Or the skit where they saw 3 different doctors and like couldn't come up with what was going on. So, I mean, it just shows me over and over and over again how there's a lot of bad care being given out there. And women are not being listened to. So you gotta change your health. And Kaiser has some very good docs. I mean, I know a lot of great people who have trained and go to Kaiser. The problem that physicians have right now is time. And I say this when I just gave a big lecture. You can't expect a menopause consult and decision making during a woman annual exam. Okay? Forget it. So you gotta like open the door, get the information, but you deserve to have either a virtual or in-person appointment with your clothes on, okay? And then, and spend the time-based appointment of 20 minutes or 40 minutes, however it takes. But I would encourage women, all of you, going in with some knowledge, and you can learn a lot at www.menopause.org. That's the society that I've been very involved with for 35 years. And there's videos, and there's also some great podcasts out there of very good people. And there are some very good books, but there are a lot of people that are spreading a lot of misinformation. I mean, I watch social media. I'm not posting very much, but I'm on it just to see what's happening out in the wild, wild west. And you know what else? You're also vulnerable.
Yeah.
And I mean, that's what makes me sick. I mean, I love the fact that menopause is having a moment out of the closet. But let me just tell you, the vulture capitals are wanting to make your money, and women are they're just completely being ripped off. And that's what makes me sad. So try to be smart about it. Oh, okay. We'll start here.
I have a question, because I never did hormone. I'm 62, been through menopause. But for the last couple of years, I tried to have aches and pains. I've had different things. I don't sleep. I sleep at 60 degrees in my room, and I have a sheet on. And that's, whoever knew how warm a sheet could be. That's all I could use. And I've been told, go to sleep study, go to pain management doctor, go to, and nobody, I mean, can I not go on anything?
Well, it's very unusual.
Because they say it will be more harm.
Yeah, right. You generally, if you are within the first 10 years and under the age of 60, starting hormone therapy, if you're on it and you can continue, that's a different story.
Right.
We generally don't start hormone therapy further out, but that's not black and white. I mean, it depends. You have to really see it like a specialist. But generally, you need to have a good indication. And, you know, I have to say, there is this woman out there on the internet all over writing books all about the musculoskeletal syndrome of menopause. Yes, arthralgias and aches and pains are part of what can happen, and estrogen really can help that. But when you're 62 having aches and pains, it's not from if 52 maybe, when you're going through your change, yes. But when you're having, it's usually arthritis, or osteoarthritis is like really rampant as we get older. You know, there are a lot of reasons. Unless you're being woken up with hot flashes, and that's the reason, and you just never took it because you were afraid. I see women all the time.
I had a couple friends who got cancer, and
they didn't want to go on it, of course.
They were on hormones.
I know. I mean, I have to say, but I would say that you don't, I'm just listening, I'm not sure that you have the indication. But definitely the vagina. I tell everybody, do not forget the vagina. And local low-dose vaginal estrogen, you can stay on the rest of your life. You don't need a progestogen if you have a uterus. Yeah, most of us don't give it when people new are over 60 to 65. On the other hand, if you went through menopause at 58 and you're 63, yeah, I mean, you're only 5 years since your final menstrual period. Sometimes we do. You know, it varies. There's no evidence that estrogen alone, that far out, is going to help your sleep. That's the
Well,
problem.
it's just, let's say,
And-
temperature is,
yeah,
it's been
yeah.
going on for a long time.
Yeah,
They've been
yeah.
telling us
Well, that's the
about it.
problem. They're lifelong. I'll tell you one of the biggest problems, and we heard a lot about this last week at the meeting. One of the biggest problems in general is sleep disorder. And honestly, estrogen's not the answer. It's not a good sleeping pill. What it is good for is if your sleep is disrupted by hot flashes. And there is, and we now have, by the way, two outstanding. They finally worked out the mechanism of action for hot flashes. And if you can't take estrogen, we now have two really excellent targeted medications. One that just was approved 2 weeks ago and coming out, it's not out yet, by Bayer, and the other is by Astellas, Vioza, which really target the area where the hot flashes are happening. And we give it a lot to our cancer survivors who can't take estrogen. And there are so many other options, but some of those other options also can cause side effects that people don't want, like the SSRIs and SNRIs or gabapentin. So, yeah, we'll take a few more and then,
Yeah.
Why don't we start here and then I'll go up
I
there.
have a quick question. I'm not questioning my gynecologist completely, but do you ever recommend Intrarosa?
Of course.
DHEA?
I would love it. So I was gonna say local low-dose vaginal estrogen, and we have ring, we have a little tablet, we have a suppository, we have cream, which is often the messiest. But Intrarosa is vaginal DHEA that gets converted into the vagina. I did all those studies too. But it's a suppository that you have to take it every single night for it to really be effective, although I know some people don't do it every night. But basically that's a very good product. It's another alternative. There's also an oral pill for this condition called GSM, genitourinary syndrome of menopause. And so that is
But it does need to be every night.
well, the studies were done and showed efficacy every night. But I'll tell you, between you and me, most of my patients, because they want to hoard it, because it's in this incredible like moisturizing stuff. So it's DHEA that in the vagina, your own enzymes convert it to a little bit of estrogen and testosterone, okay? That many women do get by using it a little less, but not like some of the estrogen products where we use it twice a week. So the efficacy on that would probably be about 5 nights a week at least. Yeah, but most people use it every night for it to be effective. You've been waiting so patiently.
So my mom doesn't even remember going through it,
Yes.
so she says, and same with my aunts, and none of my friends' moms, like nobody talked about
I
it.
know.
And I just don't know how they survived, or like, if there is and then it's done, and you're fine. Like,
Yeah.
it just,
Why don't
it's
any of
such a
them remember?
mindfuck.
Yeah, I don't know. I mean, the culture then was really, why don't any of them remember? I don't know. I really,
So
since we know
bizarre.
that women are suffering so much, a lot of women did suffer. They just suffered. No, they were really in the closet suffering. It's horrible. So, you know, I don't know if they wipe it out or what, but a lot of women did suffer, and there were lots of women who did get therapy and on therapy. You know, that's the way life goes. Make sure that you tell your daughters. I just love listening to all this here. It's so important to talk normal anatomy, normal words. Little girls should know what a vagina and a vulva is. I mean, you know, I can't even put into words how important it is. Man, my son, well, I'm here, I'm in LA because I have these 2 grandsons here. My son used to call me, Mom, I have vagina questions for you. Really, they were sex questions. So, I do have to say one thing that you guys didn't, I want to correct something. When someone has a hysterectomy, it doesn't have anything to do with your hormones. Now, this is the misinformation. A hysterectomy, you know, they have all this terminology. A total hysterectomy. Back in the day, a lot of people did do a hysterectomy, is removing the uterus, okay? And then there's the ovaries. Now, if you have a hysterectomy of some sort, and whether it be vaginal, laparoscopic, or the old days open, you interfere with the blood supply, so we know that there's maybe a year or 2 sooner menopause than you would have. But we try to leave ovaries in situ, in place. So just the word is, some people back in the day did do everything. They got rid of everything. Whereas nowadays we leave the ovaries in a lot more, or at least we take the fallopian tubes now and leave the ovaries, because there are studies showing a reduction in ovarian cancer risk by removing the fallopian tubes, which are the tubes. So if anybody's gonna have a hysterectomy, have them take your tubes and leave your ovaries. But so probably these people were referring to the fact it wasn't the hysterectomy that made them go into menopause. It was the fact that they have their ovaries out with their uterus. Then there are those who get their ovaries out and leave their uterus. So that's another whole story. Yes.
One more, is that okay, Dr.?
Yeah. Oh yeah.
One more question?
I'll do two more. One here,
Two more?
one up there.
Okay.
Okay. Didn't you have one?
Well, I was kind of helping under what we were talking about, just kind of wondering, and I know everybody's different, but like, is there light at the end of the tunnel? Like, is there a phase if you go through a long extended
Absolutely.
menopause and
I have to tell you, the worst is the perimenopausal transition. It wreaks havoc on people, I swear. I mean, I think that a lot of people really, or the peak incidence of hot flashes and all these symptoms, if you're not going to be treated with anything, generally is with or before, during, and after the final menstrual period. That's what we call it, okay? But when you get further down the road, and if you're lucky enough where your hot flashes become less severe, less intense, not for all women, okay? Things kind of stabilize out. And frankly, you heard, I love that your actress who did the older women.
Right here.
Right
Oh
now.
my God, it was so great. And every single vignette was so right on.
Yeah.
There are some women who feel liberated. You don't have to worry about getting pregnant.
Yeah.
Get something going in that vagina. They have great sex for the first time in their life. They're not worried that the kids are in the next room, or they're not like looking at the ceiling and thinking about the laundry list, okay? And so many people love that part of life. You've got financial security, you can travel in more luxury. I mean, it's a whole different phase of life. Not everybody's miserable going through menopause, okay? And you have different kinds of worries. But when you're going through the transition, yes, for many women it does get better. But there are others that really suffer. I mean, seriously, I've seen people suffer for. One other fact from that big study I told you about, they broke it down by ethnicity, and something was confirmed. Black women have the most severe and the longest hot flashes. You heard it. And it is and that study where I told you it was 7.2 years, when they broke it down, black women, the median was 10.2 years.
Jesus.
That means that some women are suffering for 20 years. Okay? But it's true. And then Hispanic women next, and then it was Caucasian, and then Asian women. And why? It's hard to say. There's a lot of theories about it. But I will say that a lot of women, really suffer for a long time, and they shouldn't. There's no reason to be suffering in 2025. Let me tell you.
Yeah.
So one more, and then I'll say thank you. And it's been a privilege to be here with all of you. I loved all of you. And this, oh my God. I was like, woo. You had one.
Thanks so much for joining us. I'm really curious. So I take estradiol by injection.
Yes.
Gender affirming.
Yes, that's different. Totally different.
And I've never heard of injecting estradiol for cisgender women going through menopause.
I know.
But in the trans community, it's like the gold standard.
I know, but you're taking a lot more also, okay? So, and it can be, I know, but most, I don't know, different ages of trans, it's very different. You're getting a lot more. Menopausal women, let me just describe something to you. The menopausal women are taking really low doses to treat hot flashes, to preserve their bone mass, or to allow them to sleep, or yes, going through perimenopause. There are some studies about estrogen helping you with that mood, or that anxiety, or that rage, or whatever. But it's back in the day when I joined this all-male group. I was literally the first woman in the East Bay practicing OBGYN. And I had left UCSF, I taught there, but I was my senior partners used to periodically give injections to women. But the studies show, again, you get this rapid increase of a huge amount in IM or sub-Q, and then it's unclear how it goes down, and it can be dangerous. Now, you remember, you're younger, so a lot of these women, the average age is 51, 52, it can be very dangerous, just with the problem with the pellets, where we see blood clots and strokes, and more risks for cardiovascular disease. So we generally use transdermal or oral, very low doses, much lower. You know that hormone therapy, your ovaries are low. You have very little estradiol being secreted. We're giving you small amounts to treat what we're going to treat. When you're having reproductive years, everyone always wants to know, oral contraceptive pills are great, or the ring, or the patch. When you are in your reproductive years, we have to give, even though there were quote unquote lower doses than years ago, something to suppress and substitute. So we're suppressing your brain from connecting to your ovary, from putting out the ovulation and the estrogen and so you don't get pregnant, right? So most birth control pills are between 3 to 4, sometimes 5 times more potent. It's a different estrogen. It's an ethinyl estradiol and a few others. So we have to suppress your ovaries from doing their thing, but we're trying to make it a straight line. And when you're going through the perimenopausal transition, for many women, the best thing to do is to be on a very low dose, or a contraceptive pill, or the ring continuously. You don't take a break. And it keeps you very even till around the age of 54, 55, when at 55, 90% of women have been through menopause. And then we transition to the other. And the other is totally different, much lower. And somehow birth control pills have gotten a bad rap on the internet when there's a lower risk of ovarian cancer, a lower risk of uterine cancer. There's a lot of health benefits to being on a birth control pill in a perimenopause. So if you don't smoke, if you smoke, you stop them at 35. So with that, I thank you all.
Wow, thank you.
I love that. It's so great. I love it. It is so